Ma'am, please check once.
Just a second. Checking.
Okay, okay.
Yes, Debolina.
Okay, okay, ma'am. So we are starting. Good evening and a warm welcome to one and all to this expert conversation. Today's topic is neuropsychology and ovarian cancer. And for this topic today, we have Dr. Calliope Megari from Greece. She has PhD in neuropsychology. She is an experienced psychologist working in the hospital and healthcare industry. She is an adjunct lecturer at the University of Ioannina in Greece, skilled in clinical neuropsychology, clinical research, and learning disabilities. Next, we have today's organizer, Dr. Ritu Santmani ma'am. She is very well known to all of you. Hence, a formal introduction needs to be done. So, ma'am has completed her MBBS, MD, FICOG, FIAOG, AMRCOG. She is the director at Pune Test Tube Baby Center and Shyam Women Clinic as an obstetrician and gynecologist, cosmetologist, and IVF specialist. Over to you, ma'am, for the next proceedings.
Yeah, thank you. Thank you. Thank you, Debolina. And thank you, Clarinet team. So friends, before we start the session, as all of you are aware, today is a very, very auspicious day. We are having a second day of Diwali. So a very, very happy Diwali to all of you. And today we are honored to have with us Dr. Calliope Megari with us. In spite of having a very busy schedule, she accepted my invitation. So Doctor, we are honored to have you with us. So friends, as all of you are aware, this session, the icons in conversation with Dr. Ritu. In this, we are taking the different topics, and this is a knowledge sharing global forum. Sorry for this crackers noise. There are a lot of crackers and crackers everywhere. So this is knowledge sharing global forum. Here we are every week on Thursday. We are coming at 8 p.m. Indian Standard Time with the different fraternities specialists, which will discuss on the particular topic. And today, Dr. Calliope is going to discuss with us a very, very important topic regarding the neuropsychology in the patients of the ovarian cancer. As we all gynecologists are treating so many patients of the cancers, and how much this affects the patient psychology also. So first we will hear from Dr. Calliope, and later on we can take your question answers. So friends, request to all of you, those who have joined, please put your questions in the chat box. Once the conversation is finished, then we can take that question answer. So over to you, Dr. Calliope. Once again, a very, very warm welcome. Here in India, we say namaste, a very, very warm welcome.
Namaste.
Oh, so sweet.
Happy Diwali to all of you. Dr. Sandwani, thank you for the invitation. It's an honor for me to be here with you. And in Greece, we love Indian people, people from India, and I love your culture and your civilization. So I'm very happy to be here with you. I will start my presentation right now. I will share my screen. Are you able to share, to see
Yes.
my, okay, I'm glad. Well, I will speak about the neuropsychological impact of ovarian cancer, but before I start my presentation, let me introduce myself, my city, and my university. I'm Dr. Calliope Megari, a postdoctoral researcher at Lab of Cognitive Neuroscience, School of Psychology of Aristotle University of Thessaloniki. I'm an adjunct lecturer at University of Ioannina and University of Western Macedonia in Greece. I'm the head of the Center of Creative Activities of Children with Disabilities in the Municipality of Kalamaria in Thessaloniki, Greece. I'm a counseling psychologist at Prison of Thessaloniki Gavata at the School of Second Chance. I was a global engagement representative of International Neuropsychological Society and research fellow at University General Hospital of Thessaloniki, AHEPA, at the Department of Cardiothoracic Surgery. I'm editor-in-chief of a Journal of Psychiatry and Mental Health, and I'm a General Secretary of Board of Directors and Ethics Committee President of Hellenic Neuropsychological Society. Now, let me introduce my city, Thessaloniki. It's the second largest city in Greece. Its nickname is the co-capital, a reference to its historical status of co-reigning city of the Eastern Roman Byzantine Empire alongside Constantinople. Thessaloniki is Greece's second major economic, industrial, commercial, and political center. It's a major transportation hub for Greece and Southeastern Europe, notably through the port of Thessaloniki. The city is renowned for its festivals, events, and vibrant cultural life in general, and is considered to be Greece's cultural capital. This is my city, Thessaloniki. You should come when you have the chance and when things with COVID-19 are over. And these are the historical monuments of the city, which are by the sea. And now Aristotle University of Thessaloniki is the largest university in Greece. The main campus is located in the center of the city of Thessaloniki and covers an area of about 33.4 hectares. It comprises 10 faculties, which consist of 40 schools and one single school faculty. Aristotle University stresses our role in the European and international knowledge community by building upon collective and personal academic achievements, enhances our visibility among the traditionally prestigious academic institutions all over the world by establishing long-term cooperation schemes at research, education, and training level. This is Aristotle, the Greek philosopher and polymath during the classic period in ancient Greece, where Aristotle University named after him. And this is the campus of Aristotle University of Thessaloniki. And now School of Psychology. Founded in 1993, the School of Psychology has a worldwide reputation for high-quality teaching and research. The school also provides students with theoretical and practical training directly related to their main field of study, aiming to prepare them for further study in disciplines related to psychology. The School of Psychology consists of 3 departments, which coordinate teaching and research, implementing programs and activities that help faculty members fulfill their multiple roles. There is the Department of Experimental and Cognitive Psychology, the Department of Developmental and Educational Psychology, and the Department of Social and Clinical Psychology. Offers BA Honors, Master of Sciences, and PhD degrees as part of its undergraduate and graduate studies program. This is the School of Psychology of Aristotle University of Thessaloniki. And now my research, post-chemotherapy cognitive impairment. Chemotherapy can cause common eating problems, such as appetite changes, nausea, swallowing problems, taste and smell changes, as well as weight changes. Post-chemotherapy cognitive impairment, other terms used, cognitive dysfunction, chemopain or chemofog, is referred to a decrease in performance of neuropsychological measures after chemotherapy for the treatment of cancer. Chemotherapeutic drugs are cytotoxic, affecting both normal and cancer cells, and contribute to the cognitive impairment observed in some individuals following chemotherapy treatment. Cancer patients have many different emotions and sometimes can be difficult to cope with. Concern regarding PCCI began after patients, especially those with breast cancer, complained about cognitive difficulties during and after cancer treatment. Cognitive domains that seemed more affected were attention and memory, and these were more commonly reported by patients with cancer during and up to years after treatment and negatively affected quality of life and their ability for work. Ovarian cancer patients. Cancer and its treatment can sometimes cause some problems. Patients may experience a wide variety of emotions, such as anxiety, depression, negative mood, but positive mood as well. Ovarian cancer shows a range of psychological symptoms during stages of diagnosis, treatment, and survival. Women at risk for ovarian cancer who attended screening programs are vulnerable to high levels of depression and anxiety, particularly young women with poor social support. And this is at the Eugenio Cancer Hospital when my research took place. And now my study, the method of my study. We investigated the manifestation of cognitive impairment related to chemotherapy before chemotherapy at T1, immediately after chemotherapy at T2, and 6 months later at T3 among 187 adult patients. 93 were male and 94 were female, with different types of cancer: breast cancer, colorectal, prostate, and ovarian cancer, receiving first-line intravenous chemotherapy for various types of cancer. Cognitive functions were assessed, such as attention and working memory, visual spatial perception, executive functions, complex scanning, and visual tracking, as well as short and long-term memory, using a battery of neuropsychological tests. We had an assessment of emotions such as anxiety, depression, positive and negative mood, to investigate the emotional functioning of cancer patients. This is the neurocognitive test battery that we have used. As you can see, we have assessed a broad range of cognitive functions and emotions as well. The results. Results reveal a statistical significance in performance immediately and 6 months post-chemotherapy at T3, although no statistically significant differences were found between the groups in any of the neuropsychological tests before chemotherapy. Patients showed lower performance immediately post-chemotherapy at T2 that remained stable at 6 months post-chemotherapy at T3 compared to T2 in all cognitive domains. Patients with breast cancer showed a significantly lower performance on all cognitive domains compared to other patients. In addition, all patients had a low performance at T2, which means low emotional functioning with no statistical significant changes. At T3, all patients had an increased performance with increased emotional functional 6 months post-chemotherapy. As you can see by this graph, cognitive decline in each group. Female have worse performance compared to men, and patients showed decline immediately post-chemotherapy at T2. All patients show cognitive decline at T2 that reduced at T3, which means 6 months post-chemotherapy. Now, our conclusions. There are symptoms of depression and anxiety among ovarian cancer patients that are decreased 6 months post-chemotherapy. Ovarian cancer patients show cognitive decline to a lesser extent compared to breast cancer patients. Medical workers and patient caregivers should pay more attention to hope and then to intervene perceived stress among patients with ovarian cancer. And of course, medical workers and patient caregivers must keep in mind the cognitive impairment of ovarian cancer and all types of cancer as well. It's important that healthcare costs to be reduced, leading to recovered patients, optimal neurocognitive functioning. Permanent cognitive dysfunction influences independent living. Cognitive decline is an important problem for the patient and family, and also for the community. It causes major financial burden of medical costs to the family and health services, and impacts independent living and daily activities of patients. Eating healthy foods before, during, and after treatment can help patients feel better and stay stronger. Cognitive change that can be detected with repeated testing is essential for an accurate interpretation of neuropsychological performance and nutrition in cancer patients. Present findings have important implications for targeted interventions as well as patient education on what to expect. Cognitive rehabilitation targets to improve cognitive functions and activities of daily living and enhances patient education. Cognitive and emotional outcome preserves quality of life and has important implications regarding future design of rehabilitation programs that contribute to better patients' outcome. And here we must not forget the contribution of psychologists and neuropsychologists in the treatment of cancer and especially of ovarian cancer patients. And rephrasing what Alan Bartley had told about memory, we say that perhaps the best way to appreciate the importance of cognitive system is to consider what it could be like to live without it, as cognitive system is not a single organ like the heart or liver, but an alliance of systems that work together, allowing us to learn from the past and predict the future. Thank you for your attention.
Yeah, thank you. Thank you so much, Dr. Kelopi, for a very nice and very crisp presentation.
Welcome.
So friends, if you are having any queries, we can take your question answers here. Till we are getting the questions, I am having some queries, Dr. Kelopi. So usually in India, the incidence of breast cancer these days is #1. Earlier the cervical cancer, now the breast cancer is on the peak in India. So here, most of the patients with this breast cancer, once the one patient is diagnosed, whole of the family is coming too much depressed. So in your practice, what you prefer? You do the counseling for the whole family or only for the patient?
Thank you, Dr. Ritu, for your question. This is a very important question. I prefer to conduct counseling for both the patient alone and the family as a group, a family therapy, because there are many problems and must be solved in counseling or even psychotherapy and psychotherapy session. Maybe the family and the patient will need psychotherapy as well, not only counseling. So I prefer to do both, individual counseling with the patient and then family therapy or family counseling sessions. And I believe this is very important for the patient.
True. Yeah. Thank you. So other what we are seeing here, the patients, because our today's talk is focused on the cancer. So second, what we are getting so many patients these days of the sexual dysfunction. I know this is not related for your today's topic, but lot of patients are coming these days for that also. Only 2 days back, I have a patient, a young girl. She was earlier diagnosed with a dermoid of the ovary, and later on she has gone somewhere else, and there the cancer markers have come positive. And patient is so much depressed that I told the dermoid is not cancerous. Once we remove the dermoid, it is nothing to like that. So especially the husband is very much attentive that, ma'am, once the ovaries, I told that I'm not going to remove the ovary, we are going to remove only the dermoid cyst and it is not cancerous. So they have some family history of cancer. The husband is very, very much possessive. Is it like that after removing the cyst, her sexual activity will become less? So this is a very, very common scenario we are seeing these days.
Yes, I know what you mean, and I have met this before in my practice. So it's very important for the patient to express, and the husband and the other members of the family. It depends on the situation, of course. It's very important for the patient to express herself, to say to them, even the doctor or the psychologist. I believe that it's true to send for you to send this patient to a psychologist, a counseling, to express herself. It's very important to express her feelings So in order to try to manage the feelings with the help of the psychologist and the help of her husband, of course. And the family plays a very important role because it's the network. The social support is the network for the protective network for the patient. So it's very important for the family to have some knowledge about depression and about the disease. I know that it must be very stressful for a patient to learn that she has something in her ovaries, even if it's not cancerous, if it's not a bad tumor. So it's very important to express herself and to have the social support with psychoeducational program to learn about how about her the sexual life after the removal of her problem. So it's very important for her to learn these things, to have a knowledge of these things. And of course, I understand that the physicians are not psychologists, and you have a burden. I know you have a burden to treat these patients, and you try to do your best. And I know this because I cooperate with many doctors and physicians in my practice, and I know this, that you have a burden. So you have to relieve your burden and say some words to your patient and and her family, and send her to a psychologist, of course, a counseling.
Very true, very true. Thank you, Dr. Gelupi. Dr.
Welcome.
Gelupi, this show is the experts in conversation with Dr. Ritu, so we take some non-academic questions also. So I want to know what brings your interest to do more and more studying the psychology. Is it your aim from the childhood that you become a psychologist?
Oh, this is a very interesting question. I'm glad that you're asking this question. Well, you see, when I was a teenager, I wanted to be a teacher of English language. I loved English language. I'm still loving English. And I want to be a teacher. I didn't have an idea of becoming a psychologist or something like that. And the system in Greece, when you are in the high school, in the Lyceum, and want to go to the university, I'm speaking about a public university.
Yeah.
You have to take exams, and according to the credits you have as a pupil, you will pass to the university in some different schools. And according to my grades, I succeeded in nursing school, not in English teaching school.
Okay.
So it was something weird for me because I haven't a thought of becoming a nurse. And I was thinking about things, and I said, well, I will go. I had the chance to give exams again next year if I wanted to become a teacher of English literature. But I thought that, it would be a good idea to see a different section that I used to have my experiences and all I thought I would become a teacher. So I went to nursing school. I graduated from nursing, and I found it very interesting. And my teachers were doctors, physicians, nurses, and I have a psychologist, my professor. I had a psychologist professor because we have the psychology lesson. And then I started having an interest in psychology. And I thought that many diseases have psychological background, have psychological roots, may say this word. The back, let's say the back thing of the disease, something that was in the back of the problem. It was psychological. And then I said to myself, well, maybe this is an opportunity for me to become a psychologist. And then, because my initial thought was to become a doctor, a physician, a dermatologist, or a plastic surgeon, something aesthetic for the women and the men, of course. And I thought that, well, I want to become a psychologist to learn some things about psychology, because many problems, many medical and physical problems of the patient have medical but psychological background as well. So I gave exams for a university, public university, and I succeeded in becoming a psychologist. And then I started to attend lessons and classes and say, well, this is it. I was born to become a psychologist. And after this journey of learning some things and wanting some things and about hopes and decisions, the journey ended, and I said, maybe if I had the chance to be born 100 times, I would become a psychologist.
Wow, great, great, great. Huh? Very interesting. So thank you once again, as we are not able to see any questions on the YouTube also and here also. So
can I ask you a question? Sorry for
yes.
interrupting.
No,
Can
no,
I ask you, in your practice, have you met a situation like this I described in my research, post-chemotherapy cognitive impairment in ovarian or breast cancer patients, or uterus cancer? Have you met any case of
yes, especially with the cervical cancer, post-cervical cancer, the patients after the radiotherapy and chemotherapy. I have seen so many patients of this kind of problems. Now my practice is mostly focused on infertility and cosmetology. Earlier I was doing everything. Now I'm more focused on the infertility. My main 90% practices of infertility, 10% you can say cosmetology and sexology. So, but earlier, yes, of course, I have seen a lot of patients. What the points you have bring out is very, very good. Is very, very helpful. Those who are focusing on this is very, very nice. So thank you once again, doctor, for sparing your time in spite of having your such a busy schedule. And once this corona will be over, I would definitely like to invite you in India for your sharing of your immense knowledge with all of us. Thank you.
I would be very glad. I would be very glad to come. You honored me by your invitation. And once again, I say that I love your culture. I love your dresses with beautiful colors, and I love your jewelry. I love I love all of this. So I'm very happy to see all of your cultural and clothes and things like that.
Thank you, Dr. Kalupi.
Nice to meet you.
Yeah,
Namaste.
Namaste. And thank you, Clarinet team. Special thanks to Debolina and Preeti. Yeah, over to you, Debolina. We know that today is a second day of Diwali, so everyone is busy in that for the Diwali. So even though Debolina and Preeti has accepted for that they will able to conduct the program today. So thank you, Clarinet team too.
Thank you so much, ma'am. Thank you all. We're closing.
Bye-bye.
Bye-bye.